to start. Assalamu alaikum, everyone, and welcome to our last session in phase one, Unity Through Knowledge, the initiative between the Sudan Anesthesia Board and the Sudanese Medical Association in Qatar. Today, actually, we have saved the best for last. Today, we will have Dr. Ismat Elsaigh, and he is one of our respected senior in the anesthesia department in HMC. Dr. Ismat Elsaigh was trained in Ireland in cardiac anesthesia, obstetric anesthesia, and he worked in the most prestigious and reputable hospitals over there. Dr. Elsaigh is a fellow of the Royal College of Anesthesiologists in the UK and also a fellow of the College of Anaesthetists in Dublin, Ireland, and he's a PhD degree holder. He's a teacher, and he's, as I said, one of the icons in our anesthesia department. So without further ado, we are with great pleasure and honor, I will present you Dr. Elsaigh in our lecture today, Cardiac Patient for Non-Cardiac Surgery. تفضل دكتور الصايغ.
بسم الله الرحمن الرحيم. السلام عليكم. Thank you for Sudak. Thank you, Dr. Hayat, Dr. Inas, Dr. Khalid, and the organizer, and of course you for having me tonight. This is a broad topic. It is impossible to cover everything in this very limited time. Also, it is very basic. It is mainly for those general trainee and those taking exams. It is not suitable for those looking for very advanced information, and it is based on the last year 2024 American guidelines and 2022 European guidelines. As we always looking for something strong like European Mercedes combined with luxury of the American Catholic اللي عندنا بنسميه في السودان ما يسمى بخاتف لونين. We take a bit from both of them, but if you prefer our ATUS or CLIC, that means our local guidelines, the Guinea we know better, that is okay also. Please don't get me wrong. I have a great respect for our local guidelines, as great deal of what we are going to talk about tonight is not available for the majority of us in Sudan. So let's start. So this is a first mandatory slide in the state of Qatar. You have to disclose that you have no conflict of interest, and I have nothing to declare. So here is our outline for our talk tonight. We go overview of cardiac patient for non-cardiac surgery. We look at optimal approach to patient care, and then we pre-operative phase. We go through risk assessment and diagnostic testing, and then we do a stepwise approach to perioperative cardiac assessment. And then we talk about guideline-directed management and therapy. And then we talk about some specific cardiac morbidities and their management. We start with coronary artery disease, heart failure, arrhythmias. Although Dr. Usman talked last week, we only going to talk about atrial fibrillation this time. We'll talk about hypertrophic cardiomyopathy. We'll talk about valvular heart disease, pulmonary hypertension, and adult congenital heart disease. As devices frequently used nowadays, cardiac implantable electronic devices. We'll talk a little bit about them, and then we talk about anesthetic medication management and intra and post-operative management. And then we finish with goodies or take-home messages. So overview of our talk tonight. Multiple cardiovascular risk factors are reported in over 45% of surgical patients age more than 45 years old. Coronary artery disease is very prevalent, like 18% of patients undergoing major non-cardiac surgery having coronary artery disease, and the number is rising. That is because the population are getting older and better detection and better care. Also, improve awareness of cardiac surgery outcome means that more patients with period corrective cardiac surgery are going to have non-cardiac surgery nowadays. In adults more than 45 years old, death, myocardial infarction, ischemic strokes are occurring in 3% of patients. We have to, this is very important, we have to, something special for cardiac patient, surgery-induced stress in cardiac patient can cause serious complication. The key is to understand the cardiac disease, which will help you to select the suitable anesthetics. I have to emphasize this, skills is more major in choosing and administering anesthesia is more crucial than the specific anesthetic drugs. So what is the optimal care for these patients? In the preoperative phase, you have to perform detailed evaluations. You have to assess and classify a risk accurately. And you have to prepare yourself to ensure readiness for surgery. And then intraoperative phase, you ensure induction is smooth and efficient. You don't want a patient to move or to be stressed at induction. And then you keep continuous attentive monitoring throughout the procedure. And then manage emergence and recovery with care to promote stability. Post-operatively, you need to maintain ongoing surveillance and vigilance to support patient recovery. So the preoperative phase, the purpose is to evaluate the patient current medical status, to provide clinical risk profiling, and decide whether you need further testing or not. Treat the modifiable risk factors, means optimizing the patient, and plan your management in all intraoperative and perioperative period. So here you can see the summary of that. You assess the risk, you order relevant test, and then you optimize your patient to make them in best possible situation. And then you formulate a plan for your management. Something we tend to forget a lot, that is the patient. And this in the setting of the cardiac patient, it is very important to inform the patient about and probably their relative, because there is a risk here. At least that will allay the stress and reduce the anxiety surrounding the surgery. So first we start with the assessment of the risk. So what are those risks? So there is a interplay of between the surgical and patient risk which cause the cardiovascular complications. So in the middle here, you will find a surgical risk, which is from low to high, and then patient-related risk about comorbidity, aging, like metabolic diseases, chronic kidney diseases, and then here whether the patient has a acute coronary. So I having some technical problem. Just my slides is not showing the top. Yeah. Okay. Now it can show. Yeah. The other factors, thrombotic and bleeding risk, which acute chronic coronary syndrome, and if you withdraw or continue those, so you balance the bleeding and thrombotic risk. The other patient risk factors, the hemodynamic and arrhythmic risk, like disorders, the diastolic dysfunction, pulmonary congestions, and then hypoxic, hypotensive, and hypovolemic risk. If the patient has the valvular heart disease or problem with the gas exchange. So now we come to clinical risk evaluation. There is as we said, patient-related risk that was range from low to high, and surgery-related risk as well from low to high. And if you get a high-risk surgery and high-risk patient, probably you consider avoid or postpone the surgery. And if you manage to reduce the risk either of the surgery, I mean, use a lower technique or manage to reduce the patient risk, then you get away with varying degree of attention. So now we come to some definitions. What is meant by emergency? That is immediate threat to life or limb. That is you need to do in less than 2 hours. What about urgent? That is you have between 24 hours. Time sensitive, you have up to 3 months. Elective, we know, all of us, we know elective. So in relation to the risk, low risk, that is combined surgical and patient risk, which predict low risk of major adverse cardiac event of less than 0.1%. It seems the magic number is 1%. So low risk, less than 1. Elevated risk is more than 1%. So risk related to the type of surgery, elevated risk more than 1. Those are major surgery, aortic, vascular surgery, peripheral vascular disease, prolonged procedures with fluid shift, carotid surgery, head and neck surgery, prostate surgery. Low risk, less than 1%, endoscopic, superficial procedures, cataract surgery, breast surgery. So we have a number of risk indices or risk assessment tools. This is back to 1977, Goldman Index, cardiac risk. Then in 1999, revised cardiac risk index, the one which personally I use this one. and then Gupta risk calculator for perioperative myocardial infarction or cardiac risk. This is endorsed by National Surgical Quality Improvement Program in the US. And then we have American College of Surgeons, also endorsed by National Surgical Quality Improvement Program. We have surgical outcome risk 2014. We have geriatric sensitive risk, and we have this AUB has 2 cardiovascular risk index, which is American University of Beirut heart disease, looking at age, anemia, surgery, everything into parameters. This here is the how significant is the evidence. This is the American guidelines. The recommendation is 2A. BNR. To understand this, we'll go to the next slide and then come back. So this is here is the risk classification. This will help you in any other guidelines. So the class or the strength of recommendation, class 1, obviously strong. The benefit is way more than the risk. Class 2A is moderate. Benefit is still higher than the risk. Class 2B, which is the benefit equal or more than the risk. Class 3, the benefit more or less equal the risk. Class 3, harm, which the risk is more than the benefit. And how they come to conclusion in those classes, this is lead us to the level of or the quality of evidence. Level A, which is higher, which is high quality, more than one randomized controlled trial. Level 2, there is 2 of them. One level B are randomized, or level B non-randomized. Level C is also 2. One is limited data, one is expert opinion. So that is the lowest available evidence. So back to our risk indices. This is the class of recommendation is 2A, probably is very good. As we said, one is the best. This is 2A, is still best. So in patient with non-cardiovascular disease, we consider for non-cardiac surgery, we use those risk indices. So now I'm going to show you how to use those. Normally there is applications you can download in your phone, but for example, we can go into do this one which I personally use because it is very simple. It is 6 steps. For example, here, high risk surgery. If you click yes, you will get down 1 point. If, for example, history of ischemic heart disease, you'll get 5% risk. If you get a history of congestive heart failure, 3.10%. As you go and breath, then it is 10% still. The highest is 10%, but you get 6 point, saying that it is 10%. So I'm going to go to show you another one. This is the American College. You can see my screen, right?
Yes.
Yes, yeah, Ismat, very clear.
Okay, so this is the other one. So you just, the American one, you have just to type the surgery, what you are going to do. For example, we use arthroplasty, and then, for example, you choose diabetes on insulin, and then you enter height, for example, 40-inch, weight, for example, 200 pounds, and then you click continue. And then it will come to you. You have your risk is 2.5, for example, on the top. You'll get you the risk of many things. You can adjust the risk if you do, for example, here you convince the risk is high, so you adjust that will adjust your risk. So if you continue, if you press continue, this will you can get that in form of PDF, or you can email it to yourself. So it is very useful tool to assess the risk of your patient. So this is another way of very simple way of assessing the risk, functional capacity assessment. Most of us familiar with this, 1 to 4 METs. METs stand for metabolic equivalent, which is 3.5 mil per kilo per minute. 1 to 4 is standard light home activities, like walking around the house, take care of yourself, eating, bathing, toilet. 5 to 9, climb flight stairs, walk up the hill, walk on 1 or 2 blocks level ground, run short distance, moderate activities like golf, dancing, mountain walk. You can just tune it to our thing. You can, for example, we have some people سك الأرنب ولا رمي السفروك, something relevant to us in Sudan. Or it can be more than 10 METs, like external sport, swimming, tennis, bicycle, heavy profession like domestic work, scrubbing floors, or عتالة مثلا في السوق. You just tune it to our environment. This is another one, more objective, called Duke Activity Status Index, or DASI. It is collecting points. The magic number of this is 34. Above 34 is good functional capacity. Below that is there is a problem. And here the evidence for the functional capacity, it is 2A. It is still very good evidence. And then this is frailty, which is mostly used in over 65 years old. For example, we don't have to go through all this, but for example, if we take the first one, physical frailty phenotype, you take 5 items, and then you give every one a point. If 0 is not frail, 1 to 2 pre-frail, 3 to 5 frail. So the evidence for frailty is still very good, 2A. So now we come to preoperative biomarkers. You did the risk assessment, and you can use biomarkers. You use those preoperatively. The commonest one we use, BMB, beta natriuretic peptide, or anti-pro-BMB. The other one is troponin. And the preoperative, that is the evidence for them. For the pro-BMB is 2A. For the troponin is a little bit less, 2B. So you did your assessment, you did your biomarker, then you got to do some testing. The simplest way is to do your 12 lead ECG available everywhere. And for those patients with coronary artery disease who has significant arrhythmia, doing ECG is good level 2A. For those patients if you in this ECG you found some abnormality, then you refer them to the cardiology. The level of that is 2A, still good. However, for asymptomatic patient, probably the level is not that great, only 2B. Still, you can do it for baseline. The other one is transthoracic echo. Mainly you are assessing the ventricular function. And you can see here the level is the best one. It is level 1. And this you do echo for every patient having dyspnea, having signs of heart failure to assess the mainly the left ventricular function. In those patients with known heart failure or some problem with the ventricular function, the level of evidence is still good to A. However, in those asymptomatic patients, to ask for echo, the level maybe is not that good. There's no benefit of doing echo for everyone. What about stress testing? You use vasodilator drugs like dipyridamole to induce vasodilatation, which will show you if there is some ischemia. And this is contraindicated, obviously, in those with asthma, with those hypotensive. The other level of stress testing is exercise stress testing. And the contraindication for that is if the patient has arthritis, he cannot exercise. The one which is commonly used as well, dobutamine stress echo. This is contraindicated if there is critical aortic stenosis or any left ventricular outflow tract obstruction. So, and here the level of evidence for stress testing for patient undergoing elevated cardiac surgery with unknown functional capacity. And when you assess them and you find elevated risk by those tools, RCRI or the American one, you can it considered good to mount to 2B. Still good. 2B is not bad. But in patients who are low risk, if you do that, you may harm your patient. So it is not recommended. What about coronary CT angio? You do coronary CT angio. The level of doing that for high risk is 2B, still okay. Risk still more than the benefit. And if you do it for low risk, there is no benefit. The level is 3. What about invasive coronary angiography? Do we need to do that in every patient? The answer is no, because they found that the benefit is very low, and actually you may harm the patient. So it is not recommended. So now you got a cardiac patient with you took the history, you did the examination, you did your risk assessment, you did testing. What is next? So To approach any patient, there is you can use this stepwise approach to the patient. We start with the patient with cardiovascular risk disease for non-cardiac surgery. If the answer is yes, then is that emergency surgery? If the answer is yes, then you proceed simply with the surgery. And what does that means? Emergency surgery, we already told the definition, that is you are saving life, saving limb. If it is not emergency surgery, then you look, is there any acute coronary syndrome? Is there any unstable cardiac arrhythmia? Is there decompensated heart failure? If the answer yes, then you are actually in trouble. You need to get other people on board with you. What we call it multidisciplinary team. You get a surgeon, cardiologist, and maybe other colleagues to decide with you. So the decision will be either you defer the surgery, you use non-invasive surgery, or only palliation. So if the patient no acute coronary syndrome, no unstable cardiac arrhythmias, or no heart failure, then you estimate the risk. You use those risk assessment tools, and you calculate your risk, and you'll see if there is any risk to modify, like severe valvular disease, severe pulmonary hypertension, elevated risk congenital heart disease, prior coronary stent, coronary artery bypass disease, pacemaker, implantable cardioverter defibrillator device, or frailty. So if the low calculated risk with none of those disease which you can modify, then you have no option but to proceed with the surgery. If there is elevated risk with also none of those what we talk about to modify, then you do 12 lead ECG in symptomatic patient, even if not established cardiovascular disease, and you start them with guideline medical therapy to reduce the risk. And if you have any of those modifiable risk with any calculated risk, then you consult the team, orthopedic or general surgery, and you maybe you need to talk about the perioperative diagnostic testing, and you do, of course, 12 lead ECG, and maybe you ask for echo for any suspected moderate severe valvular stenosis or regurgitation, or any patient with new dyspnea, or any worsening ventricular dysfunction. And again, you need to start the medical therapy to reduce the risk. So if elevated risk with no risk modifier, or risk you with any of calculated risk, then you look whether there is poor unknown functional capacity, like as we said, Duke less than 34 or METS less than 4. Then if the answer no, then again you can proceed with the surgery with no problems. If the answer is yes, then we ask the question, further testing impact in decision or change the care. If the answer is no, then again proceed with the surgery, or you can choose alternative. If the answer yes, that is means you can change by further testing, you can change the pathway, then do biomarker risk assessment. That is, as we said, pro-BNP, anti-pro-BNP, and troponin. So if you found them normal markers, then also proceed with surgery. If abnormal markers, then again share the decision with cardiology surgeon. يعني بالعربي ورط معاك ناس تانيين. So if they decide that is cardiac evaluation is the way to go, then consider echo, consider non-invasive stress testing, and consider coronary CTA. If you find low risk, then also you can proceed with the surgery. If you find the risk is elevated, high risk, and if from the MDT decides that is no need for the further testing, then basically consider something else. Consider deferring the surgery or using non-invasive or palliative surgery. And whatever you choose after post surgery, you just do postoperative troponin surveillance. So we talk a lot about guideline-directed management and therapy. What are those? It is combination of at least one antiplatelet drug, statin, beta blocker, angiotensin converting enzyme or angiotensin receptor blocker. They found that guideline-directed management therapy in coronary artery disease or heart failure with reduced ejection fraction is associated with 35% reduction in hazard and mortality at 10 years. Medical therapy usually compound with rehabilitation. So that is will start with exercise training, start with patient assessment, nutrition support, weight management, blood pressure management, lipid management, diabetic management, smoking cessation, and psychological management, and physical activity like exercise activity. So we spoke about cardiac disease in general. So now we're going to talk about some specific morbidities. We don't have time to go through all of them. There is a lot. Every one of them warrant a lecture itself. So this is about coronary artery disease. What are the problem here? So to get myocardial ischemia, that is a combination of problem related to one related to non-cardiac surgery like hypercoagulable state, inflammatory surge, hemodynamic variation, anemia or hypoxemia, or just perioperative withdrawal of those medications which normally the patient use. On the other hand, something related to coronary artery disease, like obstructive atherosclerotic plaque or vulnerable atherosclerotic one, or just that the patient had a few days recent coronary stent placement, or just the patient has a cardiomyopathy. And of course, other risk factors, there is no isolated cardiac disease. Usually there is diabetes, a lot of other comorbidity. And this is combined with oxygen supply and demand. When the demand exceed the supply, that it is great factor that we can get ischemia. Of course, you get at the end coronary acute coronary thrombosis, which causing the ischemia. Now, this is very simple flow chart. If you got a patient with coronary artery disease and you look if the surgery is emergency, then you just proceed with the surgery. You have no option. You have to save the life, you have to save the limb. If the surgery is not emergency, then you look, is there unstable patient, no acute coronary syndrome, then estimate the risk, use those tools to estimate the risk. If it is less than one, then also low risk, proceed with the surgery. If you estimate the risk and it is more than one, obviously that is high risk, then you look up the functional capacity. If the patient have very good functional capacity, then also you proceed with the surgery. If the functional capacity is less than 4 or you cannot assess the functional capacity, then you need to do non-invasive stress testing. And from the start, if the patient is unstable or acute coronary syndrome, then you need the help of the cardiology to evaluate and manage the patient. Okay, that's for the emergency surgery. What about elective surgery? So this is the flow chart for elective surgery, a patient with coronary artery syndrome, whether acute or chronic, for elective surgery. We start with acute coronary syndrome. If the patient on medical therapy, you optimize that, you adjust the dose of the ACE inhibitor, your antiplatelet therapy, and then according to each patient and according to the pathway, you optimize your patient. And here we can see class 1. What is class 1? This is the European guidelines. So I'll pause here to just to tell you what are those. So class 1 is obviously is the best evidence, is recommended or indicated. Class 2, there is two class 2. It is 2A, 2B. 2A is should be considered. Class 2B is maybe considered, where class 3 we should avoid, obviously. And just to complete the level of evidence, this show level only they have A, B, C. The European is more simpler than the American one. A is data derived from multiple randomized clinical trials. Level B, data derived from single randomized clinical trial or large non-randomized study. Level C, this is less evidence, consensus of expert or small studies. So obviously this is for the acute coronary is class 1, is higher. You have to optimize your patient before and follow the acute coronary syndrome guidelines. And as we said before, this is, you need MDT for that. Better not to decide yourself alone. You get a cardiologist, surgeon, anesthetist to discuss the case, whether to revascularize the patient before the surgery, and about all the surgery itself, like and antiplatelets and those things. So this is about acute coronary syndrome. What about chronic coronary syndrome? Again, you have to optimize your guideline, your medications, and if it is a low risk, you don't need to do anything else. You just proceed with the surgery. If the patient is intermediate risk non-cardiac surgery, you do clinical examination, you do ECG, you get a biomarker, you do functional capacity. If there is no symptoms or abnormal ECG or poor exercise tolerance or no elevated biomarker, this again, it is a very low risk, no further testing required. If you did ECG and there is abnormality, then you do transthoracic echo and stress imaging. Say and do that with troponin or and stress if there is stress, elevated troponin or stress induced ischemia. If there is none of that, then it is again you don't need to testing. But what happened if you got elevated troponin or there is stress-induced ischemia? So obviously you need to do more invasive tests. That is invasive coronary angiography. And those IWFR, FR tools used by cardiology to see if there is that narrowing need to be stented or not. It is done by cardiology. So having done that, again, you need to come together with your surgeon, with your cardiologist, and decide what you're going to do next. So here we consider low risk and intermediate risk. What about high risk? About high risk, you do clinical examination, you do ECG, you get biomarker, functional capacity, and again you do TEE, TTE, and stress imaging. And if there is no symptoms or there is no abnormal ECG or no poor exercise or exercise tolerance is good, no elevated markers, then it is low risk. You don't need any further screening. If you get those, obviously you need to do more invasive testing. So we talk about coronary revascularization. So this is reduce major adverse cardiac events in ST segment elevation MI, in non-ST elevation MI, in chronic coronary disease involving the left main coronary artery. Usually left main coronary artery, when it got involved, everybody jump around the table. That is the one which most people are worried. So again, you need your MDT to decide together if you need to consider revascularization or not. Revascularization can be applied in patients who you can postpone safely and allow time for double platelet to function. However, patient undergoing organ transplant or vascular surgery or multivessel coronary disease, it is mandatory to get together to decide whether you need to do revascularization or not, because those transplant vascular surgery, they cannot wait. And here is the level of revascularization. So normally revascularization is high level if you get a high risk and you can postpone the surgery. In patient with hemodynamically significant left main, again left main, more than 50%, and deferral of surgery is reasonable, you can go ahead and revascularize. For those patients with non-left main, where the risk is low, it is more harmful to do revascularization. So the patient had revascularization. What is next? So this is optimal time of elective or time-sensitive non-cardiac surgery for those patients who had revascularization. And they are on double antiplatelet. So if they only did balloon angioplasty, then only 2 weeks you need, and then you can do the surgery. If they use bare metal stent, then you need a month. If they use drug-eluting stent, if it is acute coronary syndrome, if the patient was for acute coronary syndrome, then you need good 1 year to go along with the surgery. But you cannot do that for time sensitive. You can accept to do it after 3 months. And the level showing that is if you do it below 1 month, that is very harmful to the patient. In relation to chronic coronary disease, you can do after 6 months. And again, you can delay the time sensitive up to 3 months. And again, it is harmful if you do less than 1 month. Our anesthesia consideration, it is almost like walking on this rope. Either you will fall or you will fall. Both options are involve falling. So what about anesthesia consideration? We find that the heart condition is significantly affect the response to anesthesia. Those patients are vulnerable to heart attack, arrhythmias, baby swings, and they need close monitoring. So our aim is to provide consistent anesthesia to maintain heart stability and to prevent sudden shift in vital signs. And you need to deeply understand what is happening, what is going on with your heart, and your drugs, obviously, and the surgical risk involved in relation to that surgery. So you can design a safe anesthesia plan. Almost supply and demand is the key element on the anesthesia for coronary artery disease. You should avoid myocardial ischemia and factor impairing oxygen supply demand balance. Those affecting decreased oxygen supply, like decreased blood pressure, and impairment of coronary blood flow. Coronary blood flow is equal pressure equal aortic diastolic minus left ventricular end diastolic pressure. And this obviously affected by coronary heart disease and stenosis. Tachycardia decrease oxygen supply, hypoxia and anemia also reduce the oxygen supply. In cardiac patient, it is recommended to have hemoglobin more than 10. Factors increase the oxygen demand. Those factors will increase the cardiac work, like heart rate. So tachycardia is bad for the heart. Myocardial contractility, wall tension, which is influenced by left ventricular and diastolic pressure and the arterial pressure. And again, I can emphasize the importance of this. Emotional and surgical anesthesia stress is major factor in increasing the oxygen demand of the patient. So keep those patients calm, give them sedation maybe before taking them to theater. And of course, avoid extremes of blood pressure. Now, this is a new disease, like a fashion nowadays, myocardial injury after non-cardiac surgery, or MINS. We're talking here about surveillance and management. So we start with troponin, If it is more than 99% of percentile, you do history, physical examination, and you do 12 lead ECG. Is the ST segment elevation? If the answer yes, then that is obviously STMI. And the patient who develop STMI after non-cardiac surgery, you should start medical therapy, and you consider angiography, balancing the risk of bleeding and the risk of uh, uh, the risk itself. If there is no ST segment elevation, then you look if there is any one of those criteria, which are the criteria for universal definition of myocardial infarction. Is there symptoms of acute myocardial ischemia, chest pain, and those things? Is there any new ischemic ECG changes? Is there development of pathologic Q wave? Is there any regional wall motion abnormality? Or if you identify thrombus, then if the answer yes, there is a feature, then that is a non-STMI. Is there acute suspicion of acute plaque rupture? If the answer is yes, then that is type 1 non-STMI. Then you consider guideline medical therapy, and balance that with the bleeding risk. And this patient may benefit from coronary angio. They take them to the cath lab, but you have again to balance the risk of bleeding from the surgery and the bleeding from the therapy which they give. If the answer is no, that is there's no suspected rupture plaque, then that is type 2 non-STMI. Then you treat the underlying cause and you optimize your medical therapy. If there is no those universal of myocardial ischemia, then this is considered post-operative myocardial injury. So we ask the question, is the myocardial injury likely due to non-ischemic process? If the answer yes, then this is non-ischemic myocardial injury. And then we simply treat the underlying cause. But if no, that is our means, which everybody is talking about, in this field. You need a discussion whether to refer this patient to a center to get their management. Okay, so that was coronary artery disease. This is now heart failure. This is NIHA. NIHA is not an Indian word. This is New York Heart Association. I'm just talking to my daughter who is sitting beside me, helping me with the technical things. So just to remind you, class 1 is no limitation of physical activity. Ordinary physical activity does not cause symptoms. Class 2 is slight limitation of physical activity. Class 3 is marked limitation of physical activity, but the patient comfortable at rest. And obviously, the worst class is class 4, severe limitation even at rest. So back to physiology. On the x-axis, the ventricular end diastolic pressure. On the y-axis is the stroke volume. So the normally graph B, when you exercise, it will go to graph A, which means that is increasing ventricular end diastolic pressure increase the stroke volume, increase the cardiac output. But with the heart failure patient, graph C, you will get no great response to increasing the end diastolic volume. And here there's two types of heart failure. On the right side of the screen, you will get heart failure with preserved ejection fraction. What does that mean? This systolic function is completely normal, but there is increase in pressure inside the heart. So as what previously they call this like diastolic dysfunction. Now, as the population increase, we're getting more and more of this. On the left side of the screen, you get heart failure with reduced ejection fraction. So regarding gold guideline directed medical therapy for heart failure with reduced ejection fraction, this include 4 medications. Again, ACE and ARB, beta blocker, mineralocorticoid receptor antagonist like spironolactone. And this is a new class of drugs, sodium glucose cotransporter 2 inhibitor. And increasingly nowadays they are using device like cardiac resynchronization therapy defibrillator. This basically coordinate the atria with the ventricle and improve the cardiac output. And here is the level for heart failure. Almost the higher level exists. That is, you should stop the SGLT inhibitor 3 or 4 days before the surgery. But in patient with compensated heart failure, on goal guideline medical therapy, better to continue those, because otherwise you get into trouble with the patient intraoperative or postoperative. Last week, Dr. Osman spoke about arrhythmia. So antiarrhythmic drugs, we don't talk a lot of them, but we talk here about atrial fibrillation. A great deal should be exercised to prevent the situation. So you optimize your hemodynamics, you correct your electrolytes, mainly potassium and magnesium. Identify those patients at risk, those with sepsis or other issues. Use pharmacological prophylaxis, those like to continue beta blocker or other antiarrhythmic drugs. So here is flow chart. I love flow charts. Here's flow chart for atrial fibrillation. This is management of patient with intra and post-operative atrial fibrillation. You look first for if there is hemodynamic instability. If there is, then you do DC cardioversion. Or you can try drugs. If the left ventricular ejection fraction is normal, or use class 1 or class 3, or if reduced left ventricular ejection fraction, use amiodarone. If you got no hemodynamic instability, you proceed to do anticoagulation, to give the patient anticoagulation. And this is done also after you did cardioversion. After you do that, you look if the patient is still symptomatic. or difficult to control the rate? If the answer is no, then try to control the rate to less than 110. If the patient preserved left ventricular ejection fraction, then you can use beta blocker, calcium channel blockers, digoxin. But if the left ventricular ejection fraction is reduced, then only beta blocker and digoxin. So you can use in any of them beta blocker and digoxin. On the other hand, if the patient is symptomatic or difficult rate control, then you try electrical cardioversion or those medication. Any of those, you have to optimize your fluid balance and oxygen delivery and your pain control. You minimize vasopressors and inotropes and continue your pharmacological prophylaxis post-operatively. And here is the evidence, the American evidence for atrial fibrillation. If the excuse me. If the patient level 2A, good level is to correct those factors which trigger the atrial fibrillation. If the patient develop atrial fibrillation, then you must anticoagulate them post-operatively. And on this chart is level 1, you have to keep them on anticoagulation. So what about hypertrophic cardiomyopathy? So our anesthesia management consideration include continue beta blocker and calcium channel blockers, avoid hypovolemia because that worsen left ventricular outflow tract obstruction, avoid hypotension, again it worsens the left ventricular out tract obstruction, prioritize the IV fluid to correct hypovolemia. And in those cases, it's better to avoid beta agonist, ephedrine, use phenylephrine, probably is best option. Consider intraoperative echocardiography monitoring. And if you got still trouble with, you have to use a beta blocker in some cases to reduce the contractility to prevent left ventricular outflow tract obstruction. In this patient, is must you have to avoid tachycardia. That will increase the timing for left ventricular filling. And here is the level is almost very harmful to use positive inotropes or any agent which can cause tachycardia. And of course, you need to maintain preload. What about valvular heart disease? We can start with mitral stenosis. The pathophysiology, you get a normal ventricular function. However, you get obstructed left atrial emptying. The blood flow from the atria to the ventricle is impaired. There is increased left atrial and pulmonary venous pressure, which lead to pulmonary congestion. And this will lead to chronic pressure elevation and pulmonary hypertension eventually, and you get a right ventricular hypertrophy because from the right side there will be increase in pressure, back pressure, which will lead to right ventricular hypertrophy. Sorry. Atrial fibrillation is very common with the mitral valve. So you focus on controlling the ventricular rate. So what about the recommendation for mitral stenosis? Is almost a very high level of evidence of a class of recommendation. If you get a severe mitral stenosis, you think about mitral valve intervention before the non-cardiac surgery. You have to rectify the valve if you can, if the surgery is elective and you can. If you cannot go mitral valve intervention, which is here labeled as class 2A, it is reasonable to guide your management with invasive monitors. If the patient has severe and you cannot undergo mitral valve intervention because before the non-cardiac surgery, then you control the rate of the heart by beta blocker, calcium channel blockers, or digoxin to prolong the diastolic filling so the heart can fill and then you get adequate cardiac output. The anesthetic management of mitral stenosis involve maintain the volume, avoid decreasing systemic vascular resistance, increase pulmonary vascular resistance, maintain a slow heart rate to allow sufficient ventricular filling. Epidural anesthesia is good for them. Again, use phenylephrine instead of ephedrine because ephedrine will increase your heart rate, decrease the filling. What about mitral regurgitation? There is persistent increase in blood volume. There is greater flexibility of ventricle without elevating left ventricular and diastolic pressure. Our anesthetic management involves aim to sustain preload because excessive preload increase regurgitation, while too little will lead to low cardiac output. Reduce the afterload is good for them because it will increase the cardiac output, while increase will worsen the regurgitation because of the back pressure. Maintain the contractility. Keep heart rate, as we said this time, either maintain the heart rate or little bit elevated, but try to avoid bradycardia because that will increase the regurgitation. And we have two categories with the mitral valve regurgitation. We have mitral valve prolapse. You need to prevent reduction in preload. You need to maintain antiarrhythmic medication. Those patients, normally they have a lot of arrhythmia. Whenever actually you get a mitral valve, you get arrhythmia. So, and here is the evidence for those suspected moderate or severe, send them to do echo. Are we running out of time? You can see Dr. Hayat. In patient with valvular heart disease
Yes, we
for...
can see Ismat. Sorry, because I have to unmute. Sorry.
Okay. No, I mean, time-wise, are we okay?
Yes, we still have time, maybe 15 minutes.
Okay, okay. So I'll tune myself. In patient with valvular heart disease who meet the indication or valvular surgery, we consider postpone the surgery to rectify the valve. And those both are class of recommendation one. For those asymptomatic patient with normal left ventricular function and systolic pressure, pulmonary artery systolic pressure less than 50, it is reasonable to go ahead with the surgery. It is level 2A. And here, if you got uh, mitral valve disease, regurgitation, scheduled for non-cardiac surgery. If you got elective or time sensitive, you do your clinical examination, ECG, biomarker. Maybe you need to TTE or TEE, transesophageal echo, and then you optimize your therapy, and you can optimize your device or cardiac resynchronization therapy. In case of if it's elective or time sensitive, you optimize your medical therapy, and then again you get along with other partners to do multidisciplinary meeting and do and decide afterward. In case of it is elective, there is a chance to do revascularization. Normally, with the mitral valve, there is coronary artery disease. So maybe most of the time they need revascularization. So after that, if you did that and there is still symptoms after the medical therapy, if there is no symptoms, then do non-cardiac surgery, but you do invasive monitoring. If there is a low risk non-cardiac surgery, then no need for additional test. If there is intermediate or high risk surgery, then you do either transcatheter edge-to-edge repair of the mitral valve. This is obviously according to the cardiologist advice. I'll show you at the end clip for that. If the patient is inoperable or high risk cardiac surgery, then do your cardiac surgery and your non-cardiac surgery with strict invasive monitoring. What about aortic stenosis? Your goals are maintain adequate intravascular volume. After load, normally those are termed fixed cardiac output situations. Usually your contractility is stable. The heart gradually adapt to bump against high pressure, but in end stage, the ventricle fail. In those cases, you have to avoid vasodilatation, treat hypertension with phenylephrine to avoid increased heart rate, avoid too slow heart rate because that will lead to low cardiac output. Too fast cause ischemia, maintain sinus rhythm, and if they go into arrhythmia, cardiovert them. And obviously, you need to prevent ischemia by avoiding tachycardia. You can use epidural or spinal for mild to moderate aortic stenosis, but it is contraindicated in severe aortic stenosis. Okay, if you got severe aortic, we just have to hurry up for the sake of time. severe aortic stenosis require elective or time sensitive. You do MDT, and cardiology anesthetist and surgery. If the asymptomatic patient with severe aortic stenosis, that is gradient more than 50 millimeter mercury, area less than 1, then you see if the patient asymptomatic, left ventricular ejection fraction more than 50, then you look if there is elevated risk of surgery. If no, then reasonable to proceed. If elevated, then can we delay the surgery? If no, then discussion in MDT and see if you can proceed. If we can delay the surgery or the ejection less than 50 or the patient symptomatic, then we see if the cardiac if the candidate is good for aortic valve replacement. If no, then you consider alternative valvoplasty or alternative procedure. If yes, then evaluate patient for aortic valve replacement and then discuss with the cardiology whether they go for surgical valve replacement or TAVI. We'll show TAVI at the end. Aortic regurgitation, the goals are normal, slightly keep them hydrated. After load, you need to lower it. Anesthesia will do that for you. Contractility, no issue. Mild tachycardia is good. Spinal and epidural is okay for them. And here is the level, basically same with the other aortic lesions. You do echo and you do valve surgery. And if it is asymptomatic, you go ahead and proceed. That is in the bottom level 2A. So our anesthesia consideration, that is, if it's stenotic valve, then that is fixed cardiac output, then they are poorly tolerated changes in heart rhythm, poorly tolerated tachycardia. Consider valve replacement before the surgery. For the regurgitant valve, you optimize your preload and the benefit from decreasing afterload. Faster heart, little bit above normal is good, and maintain preload, as we said. This is pulmonary hypertension. For the sake of time, just the evidence showing that is you go, you give the medication and you talk to the center which interested or looking after hypertension patient. Little about congenital heart disease. We need to know the anatomy. We need to know the physiology of them. They are at increased risk of mortality because of cyanosis, heart failure, poor functional capacity, pulmonary hypertension, and especially if they are. So here, just showing some diagrams of this, for example, Fontan circulation, how they correct it, and the management. You need MDT for them. We need, again, to go systematic, assess them, and know your anatomy, and talk to a center which they are deal with them, and either you send them to the center or bring the center people working there to your location to deal with them. Those devices are increasingly used. If there is above the umbilicus, the surgery, and using diathermy and those will interfere with them, you can use magnet and you obviously you need a technician to help you with those. So regarding the preoperative medications, you use continue beta blocker. You start beta blocker 1 week before. You never use interoperatively for ARB or angiotensin. You continue them for heart failure, but you stop them 24 hours for hypertension. And this, if you are using antiplatelet therapy, if you are having bleeding risk and high thrombotic risk, no, then they continue at least aspirin and you stop the other one. If you time sensitive surgery, then you bridge them, and more or less same for the oral vitamin K and the other. So for the anesthesia, is no difference to use TIV or inhalation, and no different if you use regional anesthesia. And obviously, you need to give them adequate pain block. You need to use a standard monitor, and in some selected cases, you need to use invasive monitors. And in some cases, you need to circulatory support devices like ECMO, intra-aortic balloon pump counter pulsation. The evidence for pulmonary artery is low, only in very serious sick patient, and intraoperative echo as well for serious sick patient. So now we come to the last bit of it, our goodies. So you adopt a stepwise assessment tool, do your screening and choose the specific one to avoid delaying, and do stress testing for some of them, and always try to get other people on board with you. And for new therapies, you have to stop them 3-4 days before. Now there is category of means, as we said, a new category. Atrial fibrillation, you need to anticoagulate them. You need to do some bridging for those surgery, for some surgeries, including mechanical valve, aortic valve, for example. In unexplained hemodynamic, you can use TE, focus, intraoperative. Thank you. This is our on the right, aortic TAVI, and on the left is mitral valve. So any questions?
Thank you very much, Dr. Ismat. That was comprehensive. As you said, it's a very broad topic that very challenging to be covered in one session, but I think you nailed it as we expected. And I'm so glad that we have left the best of us for last. So now you can go ahead and you can type your questions in the chat box, or just raise your hand and unmute yourself and start asking Dr. Ismat. If any question, please, we are happy to take them now.
Sorry, I had to rush to finish. As we said, as Dr. Hayat said, it is very broad topic. It is very difficult to get cover everything.
No question at all? Well, I think the job is well done, yeah, Dr. Ismat, then. Because usually these people, they flash us with question at the end of the session. Anyway, I'm happy to to pass any questions or any queries to Dr. Ismat after the session. Okay, you can always message me, reach out to me in the Telegram. Today, as you all know, is the last lecture in phase one. I'm so grateful to you for your attendance, for your interaction with the session. It has added definitely a big value to it. Yeah, Dr. Ismat, they said everything is very clear. You left no chance for them or no ambiguity to be like, questions. So,
Okay,
uh,
good. You made my day.
yeah, so all the comments are pouring positive so far. I will send you, inshallah, soon. We will send you the recorded lecture in the Telegram. And as I said, if you want any materials, Dr. Inas, she has kindly shared two important files. Regard the preoperative assessment for the cardiac patients. And if you required any from the materials that was used today by Dr. Isman, just feel free to ask us and we'll share it with you, inshallah.
شكرا دكتور عصمت، زمن
Yeah.
طويل ما لقيناك.
أهلا بروفيسور خداب. Good to see you.
2010.
كيف حوالك؟ تمام؟
الله يبارك فيك. 2010 ميلانو.
أيوة والله، زمن طويل.
الله يبارك، زمن طويل. كيف صحتك؟
الحمد لله، الله يكرمك.
I would like to thank you very much للوجبة الدسمة دي.
الله يكرمك.
يعني
بس it just had to rush to catch the time, the end of it.
فعلا فعلا. شكرا لك وشكرا لحياة وشكرا لأي واحد شارك في الجهد ده. يعني الشيء اللي
والله
اتقدم ده
دي
كويس.
حاجة بسيطة، بس إن شاء الله تكون لقت واقع حسن عندكم يا بروفيسور. وإن شاء الله إحنا we will brainstorm for another phase يكون useful ويكون مفيد للناس، ونقدر نقدم به أي حاجة يعني تساعد في الظروف الصعبة دي.
والله هي كانت يعني مشهيات للنواب. يعني الفيدباك بتاعهم كان كويس جدا جدا. هما المادة اللي اتقدمت كمان، يعني حكاية إنه يكون يعني متحفزين إنه يعرفوا مور أم مور، هي ذاتها فايدة يعني قد ما تكونوا حاسين بها. فشكرا جزيلا لكم، ونتوقع أو نترجاكم تقدموا المزيد يعني.
إن شاء الله. إن شاء الله. والله يا بروف هداب، أنا بفتكر ذاته يعني you said يعني the example very يعني bright here، بأنك كنت دايما حريص على الحضور. أنا بشكرك، بشكر دكتور منتصر عبد السخي، كل السينيورز اللي كانوا بيكونوا قاعدين ومتواجدين معانا. أنا بفتكر ده يعني ذاته مثل كويس إنكم تكونوا أول الحضور في المحاضرات دي. ودي حاجة إحنا ذاتها خلتنا يعني انه نواصل يعني بانثوزيازم. انا بشكرك شديد على على الكلمات الطيبة. بشكر زملائي في رابطة اطباء السودانيين بدولة قطر، وبشكر كل الأطباء التخدير اللي ساعدونا في إنجاح المبادرة دي في مؤسسة حمد الطبية. كمية من الأطباء والله العظيم يعني أبدو استعدادهم للمشاركة في فيس 2، وإحنا بنوعدكم إنها حتكون على مستوى كبير، يعني ارضوا طموحاتكم وأكثر إن شاء الله. ربنا يجعله كله في ميزان حسنات الناس المشاركين بوقتهم وجهدهم. Thank you. We might stop the recording يا خالد now.